Dr. Harish.
So the 8 minutes for the presentation and 2 minutes for the discussion. So our judges are Dr. Vikram S and Dr. Prithviraj. Dr. Vikram?
Yes, sir. Yes, sir.
Harish.
Yeah, welcome,
Harish.
sir. Welcome, Dr. Prithviraj and Dr. Vikram.
Good evening,
Harish.
Harish.
Sir.
Harish.
Yes, sir.
Dr. Venkat here.
Yes, sir.
Please stop the recording and restart. It will be good for sharing later.
Shall we start, sir?
Yes, sir. Yes, sir.
Good evening, respected faculty.
Retrospective study of outcomes of non-operative management of patients with liver trauma. Dr. Vishnu.
Good evening, respected faculty and my dear colleagues. So today our paper presentation is on retrospective study on the outcomes of non-operative management of patients with liver trauma. As we know, the liver is most regularly injured abdominal organs in abdominal trauma, accounting for up to 5% of all the admissions due to trauma, and accounts for up to 10 to 15% of the mortality accounting in patients with abdominal trauma. It is graded as per the AAST grading from grade 1 to grade 6, where grade 3 onwards up to 25% to 75% of liver laceration, and grade 6 constitutes complete hepatic avulsion. Earlier, most of these cases were managed. Most of these cases were managed conservatively with exploratory laparotomy. However, there is a recent trend towards non-operative management. With this background, we took this study with the following objectives: to assess the outcomes of non-operative management in patients with liver trauma, and if there is failure of non-operative management or there is any mortality, what are the factors accounting for the same. The methodology was a retrospective study done between 2016 and 19, and data were collected and analyzed. Patients with abdominal trauma were included, and pediatric trauma and hemodynamically unstable patients were excluded from the study. Various clinical parametric data, investigation parameters, the various operative management procedures were all collected. This is just a representative image just to show the CT grading of various liver injuries. As we can see, in grade 5 liver injury, there is up to 75%, more than 75% damage to the hepatic parenchyma. So the results in our study were as follows. A total of 136 cases were included, with blunt abdominal injuries, 123 cases, and penetrating trauma, 13 cases. Total patients with liver trauma were 58 cases after meeting the excluding criteria, exclusion. Total cases were 49. Now it can be divided into patients with isolated liver injury, containing 29 patients, and liver plus associated trauma, 20 patients. As we can see, most of the patients with isolated liver injury, 90% of the cases have been non-operatively managed. However, the operative management in up to 40% associated trauma. This is a chart showing various distribution of the patients according to the grades of injury, where green color shows the non-operatively managed, which is predominantly in up to grade 1 to grade 3, where the number of operative cases is more in grade 4 and grade 5. As we can see in this tabular column, the operative need has been increased with increasing the grade of the injury. So I'll be talking about the patients with only isolated liver injuries, where the total number of patients requiring surgery was only in grade 4 and grade 5, and all the patients with grade 1 to grade 3 have been non-operatively managed. What are the indications for surgery in patients with isolated liver injury, where higher grade of liver injury, and the procedures we have done are suturing, perihepatic packing. This is some operative images showing the closure of with the laceration, and another image representative of ongoing bleeding when we have done a diagnostic lab. Talking about the mortality in patients with isolated liver injury, it was the total overall 7 cases out of 49 patients have died. In that, isolated liver mortality accounting is up to 6% of the cases. The causes being hemodynamic instability, acidosis, and bile leak in one of the patients with peritonitis. Talking about liver and associated injuries, as we can see here, there is a significantly increased number of patients who are requiring operative management. Predominantly, it is because of the associated injuries. Mainly in our study, we have found that associated injuries, up to 35% of the patients are other abdominal traumas, that is splenic injuries, kidney injuries, and hollow viscous perforation, followed by chest trauma extremity injuries and traumatic brain injury and other pelvic injuries. Now, various indications for surgery in these patients and the various procedures performed have been tabulated here, where we have seen address the hollow viscous perforations and spleen injuries with splenectomy. The overall mortality in this case, in these patients are higher, that accounting for 8% of the cases. The cause of death was severe traumatic brain injury in few patients, pulmonary contusions, and respiratory distress in one of the patients. So, overall, in both the subsets of the patients put together, associated injuries are found to be 54% as an indication for surgery, followed by hemodynamic instability, which was seen in up to 36% of the patients. Other factors like hematocrit drop, peritonitis, and contrast extravasation on CT. This is a flow chart where we are looking at the mortality in non-operative group and the operative group. In the non-operatively managed patients, the mortality was 7%, whereas it was up to 36% in patients in the operative group, showing the severity of the injuries. In the non-operative group, as we can see in this column, all the cause of mortality is due to associated injuries. However, in this patients with operative group, the higher grade of injury was responsible for the mortality. So this is overall tabular column where we have divided the each patient according to grade of injury and the kind of intervention they have received. Coming to discussion, blunt abdominal trauma and penetrating abdominal trauma account to 1/4 of the cases with patients with abdominal injuries. And minor liver injuries, grade 1 and grade 2, account for up to 90% of the cases. Various surgical procedures have been proposed. In our study, the higher grade liver injuries, they have found that they were found to require surgical intervention, and associated injuries are also another factor for surgical intervention. So, to conclude, in a modern era where intensive care and clinical evaluations and emergency surgical care is available, non-operative management must be considered as a in most cases of patients with liver trauma. However, associated injuries, hemodynamic instability, and the presence of higher grade liver injury were significantly seen to be associated with the need for operative intervention and the mortality. These are the various references which we have sought for this study. Thank you, one and all.
Paper is open for discussion.
I have one question. I think in one of your statistics, you said that there was non-operative management in grade 5 liver laceration.
Yes,
sir. And like, how was that? Like, was there the patient was hemodynamically stable, and what was?
Yes, sir. The patient was hemodynamically stable, sir. There were totally 4 cases where 2 were managed non-operatively, and one of the patients managed non-operatively succumbed to other associated injury, that is, he had severe traumatic brain injury. So that was one of the reasons the patient conservatively. Also, the patient was hemodynamically stable. And subsequent hematocrit monitoring was done, and there was no fall, and patient showed clinical signs of improvement.
Any other questions? Thank you, Dr. Vishnu, for the excellent presentation.
Out of 58, Vishnu,
Yes, sir.
out of 58 patients, what has been done?
Yes, sir.
Any embolization to control the hemorrhage? Anything has been done?
No, sir. No, sir. In our institute, none of the patients, like all these patients, none of them have required, have received angioembolization as one of the patients. We have not.
Did you have any cable or some hepatic vein injuries along with this?
No, sir.
There was one mention of foreign body in the liver. What was it?
So that was a patient with a penetrating abdominal injury where there was a nail embedded in the liver parenchyma, right lobe of the liver. So a diagnostic laparoscopy was done, and the nail was removed, and hemostasis was achieved, sir.
Okay, thank you, Dr.
Thank you, Vishnu.
For an excellent presentation.
Thank you, sir.
Vishnu. Next paper is audit of prophylactic antibiotics in clean and contaminated surgery. Dr. Abhishek.
Thank you, sir. Good evening, respected faculty and dear colleagues. We shall be presenting a paper on the audit of prophylactic antibiotics in clean and clean contaminated surgery. So, what are prophylactic antibiotics? It is the administration of an antimicrobial agent or agents prior to initiation of specific surgical procedures in order to reduce the number of microorganisms that enter the tissue or body cavities. The basic principles that govern prophylactic antibiotic therapy include use of antibiotics that are effective for expected agents at the site, plan for a single dose administration of the antibiotic during the time of induction of anesthesia, to redose the antibiotic if the surgery is prolonged, extending usually beyond 4 hours, and to limit the antibiotic regimen to no more than 24 hours after surgery for routine prophylaxis. According to the CDC, the surgical site infections can be classified anatomically as superficial incisional, deep incisional, and organ space infections. The aim of this study was to compare the incidence of surgical site infections in clean and clean contaminated cases with prophylactic versus therapeutic antibiotic therapy, and to define the type of SSI with the prophylactic and therapeutic groups. It was a retrospective study where data was collected from the medical records department from August 2018 to August 2020. And all patients who underwent clean and clean contaminated cases in an emergency or elective setting were included. Patients below the age of 18 years and beyond 65 years of age were excluded. Patients who have undergone anal and perianal surgeries were excluded. If there was gross spillage in clean contaminated surgeries or presence of strangulated hernia and gangrenous appendicitis, such patients were excluded as well. So the patients were divided into two groups: the prophylactic antibiotic group, who received a single dose of antibiotic at the time of surgery, unless the surgery was beyond 4 hours of duration, in which case they received a subsequent dose. The total number of patients was 120. This number was obtained after exclusion of 3 cases of gangrenous appendicitis and 2 cases of gross spillage from the gallbladder. The therapeutic antibiotic group included patients who have received antibiotics for duration beyond 24 hours after the surgery, including 107 cases. So the antibiotics that were used for prophylaxis in the hernia repair surgeries was amoxicillin with clavulanic acid. Cholecystectomies, a second generation cephalosporin was used. For appendectomies, a second generation cephalosporin along with metronidazole was used. The antibiotics used in the therapeutic group for the hernia surgeries was second generation cephalosporins, and for cholecystectomies and appendectomies, it was a second generation cephalosporin along with use of metronidazole. This table demonstrates the patient demographics. As we can see with the p-value, there is no statistically significant difference. Hence, the two groups were comparable. This table, this graph demonstrates the number of clean contaminated cases. As we can see, were 53 in the prophylactic group and therapeutic group had 57. The number of clean cases was 67 in the prophylactic group and 50 in the therapeutic group. This graph demonstrates the various types of clean surgeries that were done. That included, the most commonly performed was the open inguinal hernioplasty, followed by the laparoscopic inguinal hernioplasty, followed by open paraumbilical hernia repair. Other surgeries that were done included incisional hernia repair, laparoscopic paraumbilical hernia repair, thyroidectomies, parotidectomies, modified radical mastectomies, and splenectomies. The cases that were considered under clean contaminated were most commonly performed were the laparoscopic cholecystectomies, open appendectomies followed by laparoscopic appendectomy, open cholecystectomies, stoma closures, as well as CBD exploration. So out of the total patients that were 120 in the prophylactic group, 4.16% developed SSIs, whereas in the therapeutic group, 3.73% developed SSI. The p-value is 0.86 and was not statistically significant. So the rate of SSI in clean surgeries, there were no SSIs reported in this audit. Whereas in clean contaminated surgeries, there were in the prophylactic group, 4.16% SSIs were reported. In the therapeutic group, 3.73 were reported, however, with no statistical significance, thus showing that they were comparable. The organisms that were isolated in the prophylactic group from 2 patients who had undergone open appendectomies who developed SSI, Escherichia coli in 1 patient and Staphylococcus aureus in the other one, and 3 patients who had undergone laparoscopic cholecystectomy who developed SSI. The following organisms, that is Escherichia coli, Streptococcus species, and Staphylococcus was isolated. In the therapeutic antibiotic group, 2 patients again in the open appendectomy developed SSI, and isolates included E. coli and Staph aureus. And in the lap cholecystectomy group, another 2 patients from whom Klebsiella pneumoniae and E. coli were isolated. So we can in literature, the rates of SSI with prophylactic antibiotics has been shown in clean cases to be 1 to 2%, in clean contaminated cases to be up to 3%. So with from this audit, we can conclude that the prophylactic antibiotic therapy is adequate in clean and clean contaminated cases, as seen by the comparable rates of surgical site infection between the 2 groups, and there is no further need of administration of antibiotics beyond 24 hours of surgery. The surgical site infections were just superficial surgical site infections that involved only the skin and subcutaneous tissue. These are my references. Thank you.
Paper is open for discussion.
My understanding is that the prophylactic antibiotic is 1 dose given 30 minutes to 1 hour before surgery. So
Yes.
if you are extending it to 24 hours, how does it qualify as prophylactic?
So the standard definition has expanded to include a dose in case the surgery is beyond 4 hours.
That I agree. But for standard cases, I think the type of surgeries you showed, at least on paper, none of them should extend beyond 4 hours.
Yes. The definition is just it has a broader scope, and hence the duration of 24 hours was included in the definitions.
No, but I think internationally it is only 30 minutes to 1 hour before, 1 dose only, unless the surgeon feels that there is any contamination or whatever, and then you can extend. Then it is no longer called as prophylactic. It will be therapeutic.
Okay.
And other thing is, how did you define, because this is a retrospective study,
Yes,
how
sir.
did you pick these cases, to define, because you would not have had a protocol before. How did you pick these cases?
Sir, we had analyzed the medical records department, and we have gone through their OPD visits for a period of 1 month, and any documentation of first discharge from the surgical site that was sent for culture and sensitivity and had grown organisms was included, sir. However, there was 1 patient in the MRM who had developed culture negative seroma, sir. So that was not classified as an SSI.
Any other questions? Okay, thank you, Dr.
Thank you.
Abhishek, for
Thank
the
you, sir.
excellent presentation. Next paper. A study of impact of policies during various phases of lockdown on patient outcome in patients undergoing emergency surgical care. Dr. Manya.
Good evening, respected faculty and my dear friends. I'm presenting a study on the impact of lockdown policies during various phases on patient outcome. I'm Dr. Manya, final year resident from Ramaya Medical College. Similar to the Spanish influenza, during the COVID-19 took the world by a storm. During the COVID-19 pandemic, we noticed a delay in definitive care due to non-availability of primary contact medical facility, tendency towards treating acute conditions conservatively, such as acute appendicitis, acute cholecystitis, or diabetic foot. The dynamic changes of the policies during pandemic required flexible approach towards the patient care by the medical fraternity. The delay in optimal treatment for surgical cases led to increased patient morbidity and mortality. Thus, the aim of my study was to assess the impact of policies implemented during various phases during lockdown in the management of emergency surgical cases on patient outcomes. It was an ambidextrous study where data was collected from the MRD. It was study period was between from the onset of lockdown, that is 25th March 2020 till complete relaxation of lockdown, which was compared to a similar period in the previous year, that is 2019. For the purpose of my study, I've called lockdown 1 as the period of lockdown during 2020 and lockdown 2 as the lockdown in 2021. All patients admitted for emergency surgical care were included for the study. Elective surgical cases and oncosurgical cases were excluded from the study. We had a total of 110 surgical cases during the lockdown, that is 91 cases in 2020 and 19 cases in 2021. In the same period in 2019, we had 249 emergency surgical cases. To summarize the policies of lockdown of 2020, inter-district and interstate and international travel was stopped. Government hospitals at various levels, medical colleges, and empaneled private hospitals, Ayush hospitals, were shut down to non-COVID population, attending only to the pandemic. Social, political, sports, entertainment, cultural, religious functions, and other large congregations were banned unconditionally, and containment zones were declared. In contrast to this, in the lockdown of 2021, inter-district and interstate travel was allowed with RT-PCR test reports. Essential services continued, night curfew initiated, government hospitals at various levels began functioning to provide medical care to non-COVID population with separate COVID care center in place. Quarantine was instated at borders. We had more facilities in the period to continue medical care, such as RT-PCR by private labs, INAT and TrueNAT testing. In pandemic, I would like to give a few examples. Here I present a 62-year-old female diagnosed with acute cholecystitis with perforation and up to 2000 ml of intra-abdominal collection, managed conservatively with delayed presentation to our hospital. Patient underwent laparotomy, subtotal cholecystectomy and peritoneal lavage. There was necrosis of gangrene of the transverse colon, which further required an ileostomy. Another case of delayed presentation was a 68-year-old male with acute appendicitis, which was being managed conservatively at a tertiary care center in the periphery. Patient then developed signs of sepsis and was referred. On CT scan, acute appendicitis with mass formation and retroperitoneal collection of 30 cc was noted. Patient underwent laparotomy and appendicular abscess drainage. We had a 49-year-old male diagnosed with wet gangrene of left foot, who was a known case of diabetes and peripheral arterial disease. Patient had mismanaged wound by home nursing care over 3 months, and patient required left above knee amputation. We can probably say that the same could have been managed with a distal level of amputation if patient had presented early. To bring objectivity to our study, we analyzed POSSUM score for all the patients undergoing surgery. That is the physiological severity score and operative severity index to enumerate morbidity and mortality. The same was analyzed by statistics. This shows the mean POSSUM scores for patients undergoing surgery prior to lockdown and during lockdown. We can see significantly increased severity of patients at presentation during lockdown. This is an operative severity index calculated for the same patients where we see a significantly higher operative severity index during lockdown than compared to prior to lockdown. The morbidity and mortality calculated for the same also shows a significantly higher morbidity for patients undergoing surgery in lockdown period than prior to lockdown. And we see that there is no significant difference between the patients undergoing surgery. Thus, optimal care was received by all patients. Duration of hospital stay was similar, showing that early discharges, once optimally treated, was followed. During lockdown, the distance traveled by the patient is significantly higher. That is, during lockdown to the medical facility than prior to lockdown, showing that the referrals were more. During COVID-19 during COVID-19 elective surgery outpatient clinics and were suspended indefinitely to reallocate in-hospital resources, expand the number of ICU beds, and reduce personal protective equipment consumption. Further restrictions of patients' mobility were among the other factors affecting patients' behavior. Sudden lockdown announcement, along with lack of provision of alternate facilities, the lockdown of 2020 impacted livelihoods, economy, and healthcare. On evaluating the impact of lockdown in Karnataka, similar to a study conducted in Italy, a village, we note that it hindered delivery of healthcare due to altered behavior of patients requiring surgical care. Our institute, Ramaya, is a tertiary hospital which treated both COVID and non-COVID populations. Disruptions to the care are associated with higher morbidity and mortality after imposition of lockdown. While the lockdown had its merits on slowing down the spread of COVID-19, the other side to it is the adverse impact it has on the healthcare of the country. Lockdown policies taken to contain the spread of COVID-19 had a negative impact in delivering optimal surgical care due to factors which were considered in this study. These factors can be analyzed such as patient factors, that is lack of financial and family resources to seek healthcare, fear to approach the health services, and dismissal of mild complaints, and adopting alternative remedial methods such as teleconsultation, home remedies, and self-medication. Logistical factors such as inaccessibility to primary and secondary healthcare due to redistribution of healthcare workers to COVID centers, shutdown of transport facilities affecting both patients and healthcare workers, and change in patient management by healthcare system to be more conservative. We can thus conclude that the lockdown period had significant negative impact on patient morbidity and mortality, requiring emergency surgical care. These are my references.
Papers open for discussion.
I had one question to ask. Like, how many patients that you guys operated in emergency turned out to be COVID positive? Was there any mortality involved?
Pardon, sir?
Now, I wanted to find out the number of cases that you operated during the lockdown.
Yes,
How many patients turned COVID positive? Like, usually since it was an emergency cases, I think the RT-PCR reports came much after the surgery happened. So how many
Yes,
turned
sir.
positive, and were there any mortality associated with those cases?
Mortality due to COVID was not separately analyzed in our studies.
Okay. Were there any incidents of mortality because of delayed intervention?
The study included only patients who were non-COVID during the course of the study.
Okay, they were
So
non-COVID.
they didn't turn positive during the post-op period also.
Okay, all right. Do you think, is there any significant impact by the treating surgeons towards the, treating emergency cases, especially in the first lockdown?
There was an impact because we medical fraternity also opted for conservative management when possible to avoid morbidity to the patient.
Okay.
Thank you, sir.
Any other questions? Well, thank you, Dr. Manya, for the good presentation.
Thank you.
Next paper, the effect of chewing gum in reducing paralytic ileus following intra-abdominal surgery. Dr. Sandeep.
Good evening, my dear
Okay.
respected teachers and my dear friends. Myself Sandeep from Ramaya Medical Institute. I'm here to present a topic titled as Effect of Chewing Gum on Reducing the Post-Operative Ileus After Intra-Abdominal Surgery. Ileus is a major cause of morbidity in an hospitalized patient. A degree of ileus is a normal physiological response to intra-abdominal surgeries, which often resolves very quickly. However, when post-operative ileus is prolonged, it can cause significant morbidity and increase the length of hospital stay. It accounts for an incidence of 10 to 15% with an economic impact of 750 million to 1 billion annually world over. Prolonged postoperative ileus is being defined as a presence of two or more of the following factors, that is, nausea and vomiting, abdominal distension, absence of passing flatus over 24 hours, inability to tolerate oral liquids over 24 hours time duration, and a radiological confirmation on postoperative day 4 without prior resolution of postoperative ileus. The etiology of postoperative ileus is a multifactorial. The exposure of peritoneal cavity to the outside and the bowel manipulation provokes various systemic and local inflammatory responses in the intestinal muscular wall due to sympathetic activation in response to surgical stress. This favors the action of pro-inflammatory mediators such as vasoactive intestinal peptides, neurotensins, and nitric oxide, which causes an increase in leukocyte level at the surgical site, promoting a gastrointestinal hypomotility. An hypothesis says that several studies have shown that by inhibiting this inflammatory response can reduce the postoperative ileus. Some of the procedures that have been used to reduce the postoperative ileus in the past are below. Sham feeding is a procedure where food and drinks are not actually digested, but a regional cephalovagal response is activated, which promotes an increase in plasma gastrin level, substance P, and pancreatic polypeptide. Same thing, the gum chewing also shows the same response of activating the local regional cephalovagal response. The main objective of the study is to determine the effect of chewing gum for the reduction of postoperative ileus after surgery for various intra-abdominal pathologies. This is a randomized clinical trial conducted in December 2020 to September 2021 in Ramaya Medical College and Hospital, where 40 patients were included. The source of data being a patient admitted to the Ramaya Medical College Hospital undergoing surgery for intra-abdominal pathology. Inclusion criteria: patients older than 18 years undergoing elective and emergency surgeries for various intra-abdominal pathologies. The patients who has undergone multiple abdominal surgeries in the past, patients who had received abdominal radiation in the past 6 months, patients planned for post-operative ventilation, and patients with partial or complete loss of dentures or with an acute dental illness were excluded from the study. The study patients will be randomized into 2 groups based on the permittivity method. Group A consists of the patients who are advised to chew gum, and the patient group B consists of a patient who will be undergoing standard post-operative recovery care. Among the group A, the patients belonging to the group A will be asked to chew the gum from the post-operative day 1. After proper instruction, the patient is supposed to chew a gum for 4 times a day for 15 minutes at 4 intervals in a day. The chewing gum that we use is sorbitol-free chewing gum, and the patients were informed to notice the following things. This is a chewing gum card that we have used for collecting the data in a post-operative patient. This consists of various, the 5 symptoms that have been identified in case of post-operative ileus. And the passage of first flatus was recorded in this chart by either a nursing sister or an attending resident or by the patient attendant, who will be taught to notice the following things. Among the group B patients, patients will be evaluated on post-op day 1 and patients' demographic details, disease details, surgery performed, anesthesia details and investigation will be noted. And the patient will be advised to note down the time of passage of first flares. The outcome indicator of the study is calculated from the time of extubation after surgery till the passage of the first flares. This time will be calculated separately, both group A and group B arm. In this study, 40 patients were included, among 22 are male and 18 females. Among that, majority of the patients, 30 patients belonging to the ASA grade 1. These are the various surgeries that the patients belonging to the group A and group B undergo. Among that, resection and anastomosis of a small bowel and large bowel constitute for 12 samples. This is a table showing the various parameters that have been assessed during the study. Among this one, the post-operative ileus was present in 5% of a population with a gum chewing group, compared to that of 20% of population without gum chewing, with a significant p-value of 0.006. At the same time, the passage of flatus in first 48 hours is observed in 95% of the population with gum chewing, compared to 60% in a non-gum chewing, which with a significant p-value of 0.002. The median length of hospital stay is 6 days in case of a gum chewing group, compared to 8 days in a without gum chewing group. And 4 patients among the group A had hypokalemia, compared to 3 patients in a group B. The use of chewing gum after intra-abdominal surgeries was associated with decreased incidence of post-operative ileus, decreased incidence of post-operative nausea and vomiting, with early passage of flatus within first 48 hours, and also decreased length of hospital stay. Since the gum chewing is an inexpensive procedure and is not associated with higher morbidity, it can be safely used for faster post-operative recovery after intra-abdominal surgeries. These are my few references from the articles. Thank you. I'm happy to take the questions, sir.
Paper is open for discussion.
Do you follow enhanced recovery program in your hospital
Yes, sir.
for all these patients?
Yes, sir. For all intra-abdominal cases, we follow enhanced recovery after surgery protocols.
Dr. Sandeep, you're telling about sham feeding. May I know what is that?
Sir, it's an cephalovagal reflex method. This was discovered by Sham, in which the food particle is not actually swallowed. The patient is allowed to chew the gum, which will in turn activate the cephalovagal reflexes, leading to the increased secretion of gastric content, which will and also increasing the motility of the bowel.
For your kind information, I don't think it was discovered by Sham. Sham is it's a verb.
Pavlov's method, sir. This is a Pavlov's method of conditional.
Pavlov's pouch. It's like Pavlov's pouch.
Yes.
So sham feeding. Sham is not a person. It is a verb. Okay, it's not a person. You said it was discovered by Sham.
Pavlov's.
Dr. Sandeep,
Yes, sir.
out of 40 patients, how many were the lap surgery patients? How many open surgery patients? Any study
no
was?
patient operated by minimally invasive surgeries were not included in the study. Only open abdominal surgeries were included.
All the surgeries had what do you call that? Either regional or spinal anesthesia, or general anesthesia. Or what was the?
All the patients were given general anesthesia.
Only general anesthesia was included in the study.
Yes, sir.
Any other questions? Okay, shall we move on to the next paper?
Thank you, sir.
Thank you, Dr. Sandeep, for the good presentation.
Thank you, Sandeep.
Retrospective analysis of benign breast ductal diseases. Dr. Arpitha.
Good afternoon, sir. Good evening, everyone. Today I'll be presenting a paper of retrospective analysis of benign breast ductal diseases. The ductal disorders constitute all the breast diseases which have a ductal pathology, among which the ductal disorders of breast among the breast diseases constitute only 5%, among which 95% of them have benign pathology. They often present with the symptoms such as lumps, abscess, nipple discharge, which often mimic the other diseases like malignant conditions, non-ductal, and infective conditions like granulomatous lobular mastitis. Therefore, it is very crucial to diagnose them early and so that proper reassurance can be given to the patients and treatment appropriately.
Slide is not moving.
Benign ductal diseases of breast are as follows: ductectasia, periductal mastitis, intraductal papilloma. The aim was to study the signs and symptoms of benign ductal diseases of the breast and to identify the best investigations to clinch the diagnosis and to identify the most appropriate modalities of the treatment. This was a retrospective study of 41 patients who were treated at the General Surgery Department of Ramaya Hospital, Bangalore, from April 2017 to December 2020, with a follow-up period of 1 year. All women who were presented with the symptoms of benign ductal pathologies of breast were included, and who diagnosed with the benign ductal pathologies of breast were included, who aged 18 years or above. And the pregnant women and lactating women were excluded from the study. Data were analyzed and presented in the form of frequency and mean and standard deviation. Coming to the results, this is the distribution of patients by symptoms. The most commonly, the benign ductal disorders presented with a nipple discharge, which constituted 15%, followed by breast lump, which was 17%, and other symptoms such as breast pain, nipple itch, recurrent breast abscess, and nipple retraction. This is the table showing the investigations and based on the presentation, what are the investigations done. The patients who presented with a sanguineous nipple discharge, most commonly the investigation, they were investigated with a cytology followed by USG and mammography. The patient who presented with a non-sanguineous nipple discharge, the most common investigations that were done was cytology, USG, and mammography. Among this, one patient who presented with a milky discharge had a elevated serum prolactin level, who were evaluated with an MRI brain and found to have pituitary adenoma. So they were referred to the endocrinologist. And the patients who presented with a breast abscess, most commonly they underwent the FNAC followed by USG. The patients who presented with a lump, most common investigations that were done was USG and mammography. One of the patients who presented with a nipple itch also had presented with a breast lump with excoriation around the nipple. So we got the MRI breast done, and that showed the ductectasia, and that's why the MRI breast was done. And one patient presented with a nipple retraction, so for which MRI breast was done. Among the nipple discharge, most common was greenish nipple discharge. The least was serous nipple discharge we encountered in our study. This is the correlation of investigations and diagnosis. The ductectasia, the patients who were diagnosed with the ductectasia, most commonly the investigations we did was USG and mammography and the cytology. The duct papilloma, the best investigation I would say is MRI breast, which helped to delineate the ductal pathology and the number of ducts involved in the duct papilloma. Periductal mastitis, most common was USG and mammography. This is one of the patient's MRI breast showing multiple ductal dilatation. Who found to have the ductectasia, and later Hatfield's procedure was done. This is the distribution of patients by diagnosis. The most common benign ductal disorders we encountered was ductectasia, which constituted 58.5%, followed by periductal mastitis, which constituted 19.5%, and the ductal papilloma was 14%. This is the association between the symptoms and the diagnosis. Ductal, the most common presentation was nipple discharge. Like 50% of patients presented with a nipple discharge, followed by breast pain and the breast lump. Whereas the duct papilloma, the most common, 83% of patients presented with a nipple discharge, and periductal mastitis as a breast pain and the breast lump. This is a treatment which yielded successful results. Among this, 21 patients, that is 51% of patients were conservative, successfully managed by conservative management. The Hatfield's procedure was done in the 11 patient, which constituted 26%, who mainly for ductal, Hatfield's procedure was done, and microdockectomy in 2 of the patients, constituting 4.8%, which was mainly done for intraductal papilloma. This is the table showing the most common the treatment. The ductal was more commonly treated by conservative management, followed by Hatfield's procedure. Conservative management constituted for 60% and Hatfield's were 30%. Whereas duct papilloma, all patients were surgically managed. Among that, 50% were treated by Hatfield's and 33% were microdockectomy. In the periductal mastitis, 37% of patients were treated conservatively, and the rest of the patients, like rest of the patients surgically managed, like with the Hatfield's procedure and wide local excision and incision and drainage. This is the picture. This is the picture showing, intraoperative picture showing the one of the dilated duct who had a ductal ectasia, who underwent the Hatfield's procedure. Coming to the discussion, the recurrent patients who presented with a recurrent breast abscess in non-lactating women should raise a suspicion of periductal mastitis. So appropriate investigations like USG, MRI breast will help to evaluate the diagnosis of periductal mastitis and to differentiate it from other inflammatory or infective causes like recurrent breast, like tuberculosis and granulomatous lobular mastitis. In the present study, most of the patients presented with a lumps, abscess, nipple discharge, and different modalities of the treatment depends upon the severity and involvement of the disease. In conclusion, we can conclude most of the benign ductal disorders presents with the symptoms such as lumps, abscess, nipple discharge, and nipple discharge being the most common the symptom. Whoever present with a symptom such as this have a high suspicion index and should undergo investigations like other than the USG and mammography, other investigations like the cytology and MRI breast. In duct papilloma, it is being a precancerous condition. It needs more attention compared to other ductal diseases. And conservatively, most of the cases would be managed, but it depends upon the severity of the disease. So more severe cases requires the surgical treatment. In duct ectasia, most commonly were treated by conservative management, whereas the duct papilloma most commonly were treated by surgical treatment like the microdockectomy and Hatfield's procedure, because it is being a precancerous condition. So depends upon the severity of the cases, the surgical treatment. These are the references.
Paper is open for discussion. Any questions, please?
From the judges? Dr. Vikram, Prithviraj?
No questions from my side.
From the audience? Okay. So we'll move on to the next paper.
Yes, sir.
Thank you.
Thank you. Thank you, Dr. Arpitha, for a good presentation. So next paper, renal hydatid cyst, our experience. Dr. Punnet from Department of Urology.
Good evening, everyone. So today's session I'll be concluded by presenting these two rare cases, which we had the opportunity to operate in our institute. What make it is a rare because the hydatid cyst we often come across to be in the liver but not in the kidney. Hydatid cyst disease is extremely rare, as I just said. The incidence is only 2%, up to 2%, and majority we see is in the liver. Various treatment modalities are available for hydatid cyst liver disease and kidney disease as well. We share our experience in management of the renal hydatid cyst disease. So the case is the 40-year-old female. She presented in OPD with right flank pain since a year. There was a history of fever which was on and off, and also she has a history of loss of weight and appetite. There was no history of lithuriia or hematuria. There was no history of any abdominal distension or a mass, and there is no other comorbidity present in that female. There was a history of emergency laparotomy in 2012, which is due to the duodenal perforation. Our general examination was essentially normal. In the system examination for abdominal, there was a tenderness in the right lumbar region. Also, there is a vague mass which was palpated in the right lumbar on deep inspiration with no nodularity. We did the ultrasound. In this, there is a large well encapsulated cystic lesion with multiple conglomerate internal ductal cyst and juxtaposed between the liver and the right kidney, which is mostly like hydatid cyst. Also, there is a significant right hydronephrosis with the well-preserved parenchymal thickness. This is the CT KUB, which suggests of the hydatid cyst disease and the multiple loculated ductal cyst in the right kidney. There was a well-defined large cystic lesion, which is up to 17 centimeter, occupying upper and the mid pole of the right kidney with multiple cysts within it. The largest of which measuring of 8 centimeters, suggestive of ductal cyst within the foci of the wall calcification. The right kidney shows grossly dilated pelvic lyshal system with dilated ureter, which could be due to the ductal cyst, and there are also a thinned out parenchyma. The left kidney was normal, and there is a calcified hydatid cyst within the right lobe of liver as well. So pre-operatively, she received the 4 weeks of albendazole of 400 milligram as a BD dose. We did open right nephrouretectomy for the patient as it was grossly, the kidney was involved and the ureter was also involved, and also the parenchymal thickness was not there. So unlikely the patient has a preserved renal function. Left 11th flank rib cutting incision was given. Intraoperatively, there was a large hydatid cyst which was involving the upper and the mid pole of around 15 to 17 centimeter. And with a grossly dilated kidney. There was a dense adhesions which were present with mass adherent to the underlying psoas muscle. The ductal cyst was also knotted in the ureter, and the hydatid cyst removed in toto without any spillage. This is a specimen in which we can see the entire kidney and the ureter has been removed with the ductal cyst. So post-operatively, the patient went home without any comorbidity or without any events. And on discharge, the patient received tablet albendazole, 400 milligram for 8 weeks. Her histopathology report reveals that the patient, the specimen of right kidney and the ureter, the cut surface of the kidney shows corticomedullary differentiation, partially lost, with a mild dilation of the PCS system. On the cut surface of the cyst, it appears as a coconut kernels with the white and the thickened, and the cyst wall varies from 0.3 to 0.5 centimeter, and there is also separately lying ductal cyst. To conclude this histopathology, they said it's a hydatid cyst of renal disease with the chronic inflammatory changes. Coming to the second case scenario, it is a 36-year-old female with complaint of left loin pain since 2 months. There was no history of any fever, loss of weight or appetite. There is no history of any lithuriia, hematuria, or any abdominal distension or a mass or any other comorbidity. Her general examination was essentially normal, and system examination reveals the tenderness in the left lumbar region with no obvious mass. Rest of the examination was within normal limits. Ultrasound has been done, which is, and the CT has been done, which conclude that the patient has large cyst in the kidney, and the management in the preoperative period, 2 weeks of albendazole she received of 400 milligram as a BD dose. And for her, the open cystic deroofing was done with the removal of endocyst, as the images say, we can see. In this, first, the decompression of the renal hydatid cyst was done because of that the cyst was really large in size, and there were the chances that the fluid can spill intra in the abdomen. So decompression was done in the first place. Then open cyst deogrouping was done and endocyst was removed. This is a specimen which shows that the entire cyst with endocyst has been removed. Our post-operative period was essentially uneventful, and on discharge, the patient received albendazole 400 milligram for 4 weeks. So the human hydatid is endemic in the several parts of the world, including the Indian subcontinent. The disease usually occurs in person having close contact with a dog or a sheep or a cattle. In human, the hydatid disease is usually found in the liver. And as when it's come to the genitourinary involvement, it generally in the literature says is 2 to 4% of the cases, being the kidney most common affected organ. The renal hydatidosis mainly occur when the larva reaches the organ through the bloodstream, lymphatics with a direct invasion. The kidney involvement is usually the manifestation of the disseminated disease, and the isolated renal hydatidosis per se is very uncommon. I'm not going in detail for the life cycle. So, age is most commonly it's been seen between the 3rd and the 5th decade of life, usually solitary and occupies the renal cortex. Symptoms vary depending on the size and the extent of the cyst. Patient with even a large cyst may remain asymptomatic. So, as a symptom-wise, the patient can complain of pain, which is vague. The patient can present with hematuria or hypertension, or there is a hydatid. It generally occurs due to there is a rupture of the cyst in the urinary system, which has occurred in about 10 to 20% of the patients. Differential diagnosis of renal hydatid disease can be challenging. The combination of clinical history, imaging guiding, and the serology test yields a reliable diagnosis, but only on the 50% of the cases. Ultrasound and the CT are the most common imaging modality being used for the patient to diagnose with the hydatid disease. Multiloculated cysts containing daughter vesicles, floating membranes, and the ring-like calcifications, which are the findings which depict the diagnosis. And for the medical management part, mebendazole or albendazole are recommended medical management. Because of the low efficacy and associated adverse effects of albendazole, the utility of medical treatment alone is very, very limited. So the dose which is recommended is 10 to 15 milligram per kg per day in a divided dose. The usual dose for adult is 400 milligram twice daily. Absorption is improved if it is taken with a fatty meal. In a post-operative period, albendazole reduces the risk of recurrent disease by inactivating the fructose. Albendazole is generally administered beginning 1 week prior to the surgery and continue to at least 4 weeks post-operatively. Some use praziquantel in addition to albendazole, but the role of it is very limited. For the definitive treatment, as we all know, there can be alternative treatment for renal hydatid cysts that do not communicate with the urinary collecting system per se. The surgery which remains the treatment of choice for the renal hydatid cyst disease. The goal of surgery therapy consists of evacuating the cyst and obliterating the residual cavity, either with omentum. Efforts should be made to avoid the fluid spillage, which can lead to the secondary seeding of the infection, and also it can lead to anaphylactic shock. So for the definitive management as a surgery, for the cysts which are superficial, so simple cyst deroofing can be done, or it can be done as a pericystectomy. For the cysts which involve the renal parenchyma, either the partial or the total nephrectomy can be done depending upon the size of the cyst. For the cyst which involves the entire kidney and the kidney become non-functioning, then the total nephrectomy is advised. Either it can be done open or laparoscopically. So in circumstances in which the intact removal of the cyst is not feasible, proctocidal agent such as hypertonic saline should be injected into the cyst prior to the removal of the contents. In addition, the surgical field should be protected with pads soaked in the proctocidal agents. If the spillage occurred by chance, the peritoneum should be washed with hypertonic saline. The patient should be treated with albendazole 3 to 6 months. This is in the case when the spillage occurs. So the period of medical management goes up to the 3 to 6 months, and a brief course of praziquantel, which is about a week, should be administered. So WHO, which suggests, as we all know, the grading of it, I just brief it up a little bit. For the WHO CE1 stage, it is a unilocular anechoic cyst lesion with a double line sign, and it is an active stage. If the size is less than 5 centimeters, albendazole alone can be given, and if it is more than 5 centimeters, then it has to be adjunct with pair. For the grading of CE2, which is a multi-separated rosette-like honeycomb cyst, it is also an active stage of any size. Albendazole, in addition with either modified catheterization or surgery, is advocated. For CE3A, in which the cyst is detached to the membrane and water-lily sign can be observed, it is a transitional stage. So for this kind of cyst, the size is less than 5 centimeter, you can only treat the patient with albendazole. Or if it is more than 5, then it has to be adjunct with pear technique. And in CE3B, in which the cyst with daughter cyst is in a solid matrix, it is also a transitional zone. Irrespective of the size, you can advocate albendazole either with modified catheterization or surgery. For CE4, the cyst with heterogeneous hypoechoic or hyperechoic content in which there is no daughter cyst, particularly this stage is inactive of irrespective size, you can observe if patient is asymptomatic. In CE5, the solid pus calcified wall is present, it is also inactive, and irrespective of the size, it can be observed. So the complication which can happen in surgery is peritoneal dissemination, which we all know. Most commonly, if that occurs, then anaphylactic shock, hemorrhage can be there, and urinoma or urinary fistula formation can happen. In the post-operative period, as an adjunct therapy, albendazole should be given as it reduces the risk of recurrent disease. It is also causes inactivation of proctospinalis in case of spillage. To conclude my case, the renal hydatid disease is extremely rare, about 2% as the literature says, and is mostly due to the secondary manifestation of the disseminated disease. Clinical manifestation of renal hydatid disease often are non-specific. Characteristic imaging finding coupled with a history of the living in an endemic region are strongly suggestive of this diagnosis. Surgery forms the mainstay of the treatment with adjunct to the albendazole prescribed to avoid any complication or recurrence. Thank you.
Paper open for discussion.
Questions from the judge? Questions from the audience? Ravi Shankar sir, anything to say about this paper?
Dr. Punnet, the cases, both the cases which has been operated done laparoscopically or it was an open surgery?
One was open, sir, one was lap.
Okay. What are the chances of getting into malignancy? This hydatid cyst.
Sir, there is no literature, sir, that hydatid cyst can turn into malignancy. Pre-operatively, yes, it's a question that it's a simple renal cyst or it is a malignant or it is a hydatid cyst per se because it's very rare. But CT, as we say, it's a gold standard, sir. If you can see the signs of daughter cyst is present and in the contrast uptake, if it is solid lesion, then obviously we can rule out hydatid cyst from malignancy.
Any other questions?
There are no questions. We come to the end of the program.
Okay, thank you, Dr. Punnet, for an excellent presentation.
Thank you so much.
Thank you, Punnet.
So we come to the end of the program, today's program. I thank the Surgical Society, President, Secretary, and all the committee members, the office bearers, and I thank all the faculty, Department of Surgery, MS Ramaya, for making this program a success. And thank you one and all. And also the PGs who have worked hard for an excellent presentation. And Dr. Ravi, Mr. Ravi, for providing us the facility for audiovisual facility. Thank you, and thank you one and all. Dr. Harish?
Yes, sir. Thank you so much, sir. On behalf of Surgical Society Bangalore, I thank Professor Dr. Rudresh, HK, HOD of Surgery.
Thank you, sir.
So you have done a wonderful job, sir, by organizing this wonderful academic feast. The cases and posters and papers were so good. And I thank all your faculty and I congratulate all the postgraduates for their presentations. They have done a wonderful job. I thank our judges, Dr. Nagbhushan JS, Dr. Vikram S, and Dr. Prithviraj AS for judging this session. I have some few announcements to make. So
Yes,
the
sir.
next, yeah. So the next.
Thank you, Dr. Adresh. Thank you very much.
Thank
You
you,
did a
sir.
wonderful job. All your PGs, the posters, the paper, and also the teaching program was very good.
Thank you, sir.
Right.
Yeah. So
Okay,
I have announcements to make. The next MCM will be physical, hosted by Rajarajeshwari Medical College, led by Dr. Venkatesh S. HOD. The most important program conducted by Surgical Society of Bangalore in the month of November from 21st to 27th is CSCP, National CSCP program. As a part of that program, the first day, that is on 21st Sunday, is the basic surgical workshop. It is physical, conducted for 40 students. Already we have just reached the 40 students slot, so we have closed the registration. So the brief overview of the program is, it is a endotrainer session and open surgical skills session. So it is from 9 to 5 p.m. at Bangalore Medical College, Alumni Association Skill Lab, that is in a medical college. So the from 22nd to 26th is a online program that is from 5 to 8 p.m. in the evening. There will be a case presentation, and the national and the faculties will be moderating the sessions. It is a wonderful program for the postgraduate for their examination preparation. I request kindly do register for this program. Who are all not registered yet, please do register. Tomorrow by morning we are closing the slots for the registration, which entitles the CME points. Till tomorrow, they will get a credit points if they register. From tomorrow onward, they don't get a credit points, but they can still register for the CSCP program till Sunday. On Saturday, that is 27th, we have a Professor B. Anumaya Memorial Orations in the evening, 6 to 9 p.m. at Capital Hotel. It's a physical meeting. So our ASI President Abhay Dalvi will be the chief guest, and President-elect Dr. Siddesh G will be the guest of honor. It will be a wonderful program. I am just inviting cordial invitation for all of you to attend that program. So after a long break of 2 years, we are conducting this physical program for the orations. So kindly do make your time for this program. So I request all the faculties, all the HODs to encourage your PGs to register for the CSCP program and make this program the successful. So before anything to say, Dr. Venkatachala sir?
Nothing. Nothing.
So give us a minute to announce the results.